Good morning or good afternoon for those who are late in the day. My name is Sabine Karam. I'm a Lebanese nephrologist currently based in Beirut, Lebanon. I practice in an academic setting in a university hospital called St. George Hospital University Medical Center. As a background, I did my residency and my fellowship in the US, and I'm board certified in internal medicine and nephrology, and I also have a certification in hypertension by the American Society of Hypertension. Later on, I completed a master's in transplant at the University of Barcelona. And currently, my practice consists of doing general nephrology, both hemodialysis, peritoneal dialysis, taking care of transplant patients in general, but I don't work specifically as a transplant physician. I also dedicate a lot of my time to education, to medical education, and I also heavily involved in the International Society of Nephrology, where I serve on several committees. One of them is a Young Nephrologists Committee, where I occupy presently the position of Deputy Chair. Thank you for inviting me to give some answers I hope that would be useful to your listeners. So here it was a bit of a vague question, and I asked to have more specifics. So I asked about lupus nephritis. Now, if we want to talk in general about all types of glomerulonephritis, I would say there is always what we call a non-immunosuppressive therapies for all of those entities, and the immunosuppressive parts. The non-immunosuppressive part definitely requires controlling the blood pressure, ideally with ACE or ARB, ensuring lifestyle modifications such as smoking cessation, making sure that the patient is adequately vaccinated and doesn't have any active Hep B, Hep C, or HIV before he's given the treatment, or TB. If he's given aggressive immunosuppressive treatment, he should be on PCP prophylaxis with Bactrim. In case he's given like a treatment like cyclophosphamide, the patient needs to be counseled about possibility of infertility, and the dose of cyclophosphamide shouldn't exceed 36 grams lifelong. And we know cyclophosphamide is used in many types of glomerulonephritis. And we can offer, for instance, fertility preservation techniques such as congelation of sperm and eggs, etc., etc. Now, regarding specific treatment of lupus nephritis, all patients should be on hydroxychloroquine. If patients have type 3 or type 4 proliferative glomerulonephritis due to lupus, they should get a pulse of steroids. Some clinicians like to give 1 gram, but it's been more and more advocated that high dose of steroids probably don't make any difference and could have more side effects. So I personally don't go above 500 milligrams per day for the first 3 days. And then a quick taper is now advised with getting to a dose of 5 milligrams per day by week 12. Concomitantly with steroids, you can either use MMF or MPA. MMF should be given at 1 gram twice a day or 1 gram 3 times a day. Or you can offer the patient low dose cyclophosphamide IV if you think he's not going to be compliant with PO. And in that case, the Euro-Lupus regimen has been found to be as effective as NIH regimen, and that's around 500 milligram IV every 2 weeks for 3 months. In patients in whom you cannot use MMF or who are intolerant to MMF, you can reduce the dose of MMF and give concomitantly CNIs. You can also consider rituximab or leflunomide if the standard immunosuppressive therapy are not tolerated. You have a certain subset of patients who can present with nephrotic syndrome, and can have features of what we call minimal change lupus. In that case, giving them steroids is usually sufficient. So you know what I always like to tell my patients, the lifestyle changes that you need to implement should not only be useful for you as a patient who lives with chronic kidney disease, but should be useful for anybody. So in general, weight loss is advocated because obesity has been associated with worsening chronic kidney disease. Smoking cessation, a healthy diet. So there is a lot of back and forth about the ideal diet for patients with chronic kidney disease. And the largest trial, which was the MPRD trial, yielded conflicted results. But what I usually show my patients is the WHO food pyramid. And I tell them that if you already follow that pyramid, you're already indirectly having a kidney diet as advocated by a lot of renal association for renal nutrition. So looking at this pyramid, you realize that this pyramid actually leads you to have, at least 50% of your diet made of fruits and vegetables and whole grain foods. And that's precisely what people who advocate a plant-based diet tell you to do. They tell you a plant-based diet is a diet which is made 50% of fruits and vegetables. The reasoning behind the plant-based diet is following. Fruits and vegetables are converted to base, which are good for the kidney, while an animal-based diet would get the proteins converted to add, which is deleterious to the kidney. A plant-based diet, because it's rich in fruits and vegetables, is high in potassium, which would lower the blood pressure and be beneficial to the kidney. And so this is also another misconception. People think that they need to restrict the potassium regardless of the potassium level in the blood and the stage of CKD. This is completely wrong. Potassium by itself is not deleterious to the kidney. But if the patient has a very high potassium level and there is no other way to lower it except by restricting it in the diet, this is where you can consider restricting nutrients that are rich in potassium. And so this is what I tell my patients. I tell them that fruits and vegetables are highly beneficial. They should then have 50% of their protein intake being of biological value, and preferably come from lean meats and avoid red meat if possible. And that we'd be again doing them a favor in terms of cardiovascular benefits. And obviously, low sodium diet is an important armatorium to actually control the progression of chronic kidney disease. So having a low sodium diet is beneficial in terms of making ACE and ARBs more beneficial to lower the blood pressure. It decreases by itself, it would decrease the proteinuria. By itself, it would decrease the blood pressure. It would also decrease the incidence of someone having kidney stones. And the recommended target would be less than 2 grams per day, and ideally 5 grams of sodium chloride per day. And some exercise would be beneficial, so 30 minutes per day if possible. And should be also adequately vaccinated. So this is, and on a statin for all kids of that are more than 50 years old. Yes, definitely. It's hard sometimes to say where is the and where is the end. So, for instance, in terms of cardiovascular disease, we know that hypertension can lead to chronic kidney disease, but also chronic kidney disease can lead to hypertension. And the more advanced the chronic kidney disease is, the higher it is, the more the blood pressure is, and the more difficult it is to control. Second, we know that patients with chronic kidney disease have a significant cardiovascular risk. And this is why our KDIGO guidelines tell you to give a statin to any patients with CKD above 50 years of age. Third, the two most common causes of chronic kidney disease are diabetes and hypertension, and they are both, very common cardiovascular risk factors. And what's great now is we're starting to have this armamentarium of drugs protect at the same time the heart and the kidney. In that aspect, we need to mention ACE and ARBs, but also SGLT2 inhibitor with dapagliflozin, who just got approval by the FDA to be used in chronic kidney disease, not just in chronic kidney disease with diabetes. And we know that this of overwhelming vascular protection effects. And they have shown to have antifibrotic effects both on the heart and the kidney, as are ACE and so ACE and ARB exert their beneficial effects on the heart and the kidney, not just by lowering the pressure, but in the case of the kidney by lowering the intraocular pressure, but also have antifibrotic properties within the glomerulus by decreasing mesangial proliferation and having a positive effect on markers that have fibrotic properties such as FKBP and markers of oxidative stress, and et cetera, et cetera. So ACE and ARBs are back to the initial question about enalapril. ACE and ARBs are definitely recommended, strongly recommended for patients who have albuminuria of more than 300 milligram. They are suggested when the albuminuria is less than 300 milligram. Their effects have been mostly proven in patients with diabetes, but they have a reliable, proven beneficial effects in patients who have a proteinuria of more than 1 gram. Patients with CKD and who do not have diabetes. No, definitely not. And this pandemic have led to a lot of dilemmas, because we know that patients who are immunosuppressed, whether we're talking about patients on hemodialysis or peritoneal dialysis or transplant patients, or patients receiving immunosuppression for certain type of glomerular disease, are less likely to respond to vaccination, to COVID-19 vaccination. And so all sorts of strategies have been used. So some people, so definitely if patient is a candidate for transplant, it's been advocated to have them vaccinated at least 4 weeks before they receive the kidney. If they can postpone having receiving that kidney, this can be done on a living donation. But in the case of cadaveric donation, it's not always possible. Of course, the pandemic have had a lot of negative impact on kidney transplant. A lot of programs had to hold the transplant process because of that. And a lot of patients, a lot of practitioners have attempted to lower the immunosuppression before giving the vaccine, but that has an incredible rate of rejection who are transplanted. I would do that very cautiously in patients who have had more than 1 year post-transplant, and probably just lower a bit the MMF, but not other immunosuppressive drugs. For immunosuppression, then if you can afford the luxury to wait to give immunosuppression, then you could wait. For instance, I have currently a patient member in nephropathy who's in partial remission. I'm waiting to redose him on rituximab just because I can afford to wait. He has an intact eGFR. His proteinuria is around 2 grams. So I think the benefit of waiting is the risk of waiting.